Okay, so now we're going to continue with the pharmacology for Miriam Khan. Previously, we talked about the penicillins, including both penicillin G and ampicillin. I just want to make it clear that both of those are penicillins. The next class of drugs we're going to talk about are the Amino Glycosides, and we're only going to mention one, and that's gentamicin. So gentamicin works a different way. This is going to target the 30S ribosomal subunit, and the mechanism of action is officially called the inhibition of protein synthesis. We don't really know exactly how gentamicin works, but we do know that if you inhibit the activity of the 30S bacterial ribosomal subunit, you basically mess up protein synthesis and the bacteria die. So of course, gentamicin, like penicillin, is bactericidal. Okay, the side effects that you have to be aware of with gentamicin include both a nephrotoxicity and a neurotoxicity, and the neurotoxicity is associated with specifically hearing loss or ototoxicity. Things to remember about gentamicin in terms of their side effects, and board or step one boards like to talk about or like to ask questions about these. There's a little bit of a disclaimer, and so the nephrotoxicity, as the text points out, is relatively rare, but it occurs in less than a quarter of patients treated for longer than 5 days, and the nephrotoxicity is reversible, so that's good. However, the neurotoxicity, which is usually manifested by the vestibular system, particularly hearing loss, that occurs in less than even 5% of patients that are treated for more than 5 days, and that is irreversible. Okay, and so that's one thing to kind of keep in mind with these patients, is that although it's relatively rare, if they do complain of ringing in the ears or hearing loss, it's best to discontinue this drug. In terms of pharmacokinetics, we have identified a mitochondrial DNA point mutation, and so I don't know if they're screening yet for this, but at some point I would imagine this would be part of the standard kind of therapy for this particular drug, is to actually screen the patients to make sure they don't have the mutation, because those with the mutation are highly likely to develop the irreversible ototoxicity. Other side effects include hypertension, rash, itching, and so forth. Other things to remember in terms of gentamicin is, just like penicillin, patients with low kidney function, as evidenced by a low creatinine clearance, are going to need smaller doses and perhaps even therapeutic monitoring. And so the therapeutic monitoring portion comes in where the drug will be dosed at a specific time point, and then serum will be taken, and then they'll measure the amount of drug in the serum, and they'll basically kind of titer the specific dose based on that patient's renal clearance of that drug. And so you'll need that particular monitoring, because you really want to avoid both these neurotoxic and nephrotoxic side effects from even manifesting. So that was gentamicin. Most often you'll see, in terms of the therapeutic strategy, you'll see ampicillin combined with gentamicin. There hasn't officially been a clinical trial to my knowledge. The last time I looked this up, I didn't see one. But kind of the rule of thumb is that it's been done in the past, and the idea here is that you're going to use two different drugs that have two different mechanisms of action, ampicillin plus gentamicin, to essentially, target these bacteria that are producing this disease in two different ways, to basically cast a wider net. And so if they're both broad spectrum, you're increasing the amount of bacteria that you could possibly be treating. So often you'll see ampicillin and gentamicin combined for the treatment of this particular infection. And of course, once you determine what this infection is, you'll understand why maybe these two drugs were used in combination. Okay, so speaking of combination drugs, this next group of drugs are more often combined with each other as well. And so what I've done is I've separated them so we can talk about them individually, but understand that both trimethoprim and sulfamethoxazole are typically combined into one tablet or capsule, and you get both drugs at the same time. And so we'll talk about trimethoprim first. Trimethoprim is a dihydrofolate reductase inhibitor. All right. So understand that bacteria can't use foreign sources of folate. They have to synthesize it themselves, and they have to synthesize it from these intermediaries. And so that chemical reaction is shown in the next slide or two. Trimethoprim has relatively little affinity to the mammalian form of dihydrofolate reductase, but it still is associated with pretty intense side effects, which we'll talk about in a few seconds. Trimethoprim is a broad spectrum, and when used by itself, it's bacteriostatic. And so this is in contrast to the other drugs that we've talked about, which have been bactericidal. So like homicide, murder, bacteriostatic are really, bacteriostatic antibiotics are really just antibiotics that don't actively kill the cells, but they reduce the growth and proliferation of them. And so the colony doesn't expand quite quickly as it does without an antibiotic on board. Trimethoprim is a weak base, so you can see it being used for urinary tract infections because these particular drugs can concentrate in both the vagina and the prostate, so in relatively acidic environments. So when you have something like a UTI that moves from the bladder to outside of the bladder to associated organs, a drug like trimethoprim would be a good pick. Okay, and so the side effects that go with trimethoprim are pretty much the same as any other antibiotic: diarrhea, itching, vomiting, upset stomach, headache, flu-like symptoms, changes in appetite. But the ones that STEP like to ask are the rare, potentially fatal side effects, including megaloblastic anemia, leukopenia, and granulocytopenia. Okay, and so that's just something to remember about this particular drug. These side effects are relatively rare, but they do happen. Sulfamethoxazole is a similar acting compound. This is a dihydropteroate inhibitor. Okay, so then this is going after the folate metabolic pathway, which is on the next slide. When used alone, sulfamethoxazole is bacteriostatic, and for that reason, it's seldom used as a monotherapy. One thing to keep in mind that based on its chemical name and its chemical structure, it is a sulfonamide. And so this means something in terms of medicinal chemistry because some patients have allergies to these particular types of compounds. The side effects are the same, more or less, but in terms of the anemias and the thrombocytopenias. But the side effect that most often is asked on STEP stems from the medicinal chemistry of sulfamethoxazole, and that is that it has a sulfonamide type chemical structure backbone. And so that's usually associated with allergic reactions. So that's one thing to keep in mind. We'll talk about other drugs that have sulfonamide structures, diuretic agents, some of the drugs for diabetes, and a few other antibiotics are all sulfonamides. And so that's kind of the same side effect profile in terms of the potential for allergies. So as I said before, most often trimethoprim and sulfamethoxazole are combined, and they're typically combined in a 1:5 ratio, and when you combine them, it's been evidenced that they produce a synergistic effect. So both of these drugs, when used alone, are bacteriostatic. However, when you combine them, the mixture becomes bactericidal. And the reason is because essentially here's the folate pathway. You're actually inhibiting two different enzyme activities that really kind of deregulate and severely restrict folate metabolism in these bacteria. And so the side effect profile, when you combine them, are pretty much the same because there's a lot of overlap. However, it's been reported that more of the side effects associated with trimethoprim, even though it's substantially less than the amount of sulfamethoxazole, seems to kind of manifest itself. So that's just one thing to keep in mind. This may look foreign to you, but you've probably all taken this drug at some point. This is Bactrim, the brand name Bactrim, and this is the combination trimethoprim sulfamethoxazole drug. Okay, so that basically summarizes all of the drugs for Miriam Khan. If you look at the guidelines from the American College of Obstetrics and Gynecology, the first line recommendation is 6 grams per day of ampicillin given IV for 2 weeks for this particular patient. You can click on that link and you can see those guidelines. But what happens if she had a penicillin allergy? Well, the next best treatment approach would be Trimethoprim Sulfamethoxazole. Other things to kind of keep in mind is, well, how about the baby? Do we need to treat the baby? This may be one of your session level discussions. And I think it's an interesting one in terms of therapies, in terms of when you would start treating the baby, if you need to treat the baby, and for how long, of course. I'll try to put interesting tidbits about pharmacology and culture. I'm sure if you've ever taken microbiology or even pharmacology, you know that Alexander Fleming discovered penicillin. Here's a nice kind of review article that summarizes what was going on at that time. And we talked about penicillin and how you need to reduce the dose of penicillin in patients that have renal failure or compromised renal activity. This is an interesting kind of article. Some people don't remember this, but you can actually harvest penicillin from the urine, and you can recycle and re-administer this. And of course, that sounds disgusting, but when penicillin was in the short supply in the 1930s, we would collect the urine of patients that were being treated with penicillin so that we can re-extract that drug. And so it comes out basically unchanged. It's the same molecule it was as it went in. So we can kind of recycle it. So that's kind of two tidbit type of interesting historical papers that you can read if you have time. And of course, there's the references for this particular paper or project. So that's it for the pharmacology for Miriam Khan. This is the second lecture in that series. And if you have any questions, please email me. Thank you.